What is COPD? What does it stand for? All right, so chronic obstructive pulmonary disease or chronic obstructive pulmonary disorder, whatever you want to call it. What causes it? Smoking. All right. This is an irreversible and progressive airflow limitation. Once you have COPD, you can't get out of it. It ain't coming back. Okay. It changes your airways and remodels them so much that they're not going to come back to normal. Whereas asthma, you can, right? You can fix it a little bit and your symptoms can be better. All right. So most of the time, like 98% of the time, it's from smoking. But whatever, you okay? Okay. Whatever noxious gases, like if they, let's say they work and they're a painter, like not like a fancy painter, but like they like paint houses and they have all those chemicals all the time, right? Or maybe they go and clean carpets for a living. That's a lot of chemicals. So something is happening where those noxious gases are coming in and it's causing inflammation of the airways. And that happens over and over and over. What do you know about chronically inflamed cells? They get fibrotic, which means they don't, well, if your lungs don't expand, oh no, the goblet cells become very enlarged. What are the goblet cells in your lungs? What do the goblet cells in your lungs do?
Expand?
No, I hope not. What's their job? What do they produce?
Mucus?
Yes. Goblet cells produce mucus. So those become very, very enlarged. You're going to get tons and tons of mucus production. So what does our cough sound like? Yes. And because they're trying to pull air in, they can't get air back out because their alveoli gets real floppy and crappy. So they get air trapping. Their oxygen levels are going to go down, which means their CO2 levels are going to go up. So what acid base imbalance will they end up in? Respiratory acidosis. Okay. Their whole entire airway will become remodeled from the chronic inflammation. So their body stops producing collagen, which what is collagen's job? Elasticity, and it produces scar tissue instead. Can you imagine trying to breathe in through scar tissued lungs? It's very difficult to breathe. So the lungs become completely fibrotic. You with? Okay. On top of that, the parenchyma becomes destroyed. Parenchyma is just a fancy word for lung tissue. It's just lung tissue. Okay. You will have pulmonary vascular changes. What does that mean? Well, your lungs all day long are saying over and over and over. So tons and tons of fluid is coming in there, right? Into the vessels of your lungs. So that more fluid, more pressure. So they're going to get pulmonary hypertension. Anytime you change pressure in a vessel, your body says something is wrong and you leak into the third space. Where's the third space in the lungs? The alveoli. So your alveoli fill with fluid. What's the job of the alveoli? Gas exchange. Can they gas exchange when they're full of fluid? No. And then your body thinks something is wrong, so it brings its first defenders out. Who's the first defenders? Neutrophils. So the neutrophils come out and they're like, remember the neutrophils, all they do is come out and shoot everything, right? But what are they shooting when they get out there? Your lung. Okay, it's not autoimmune. It's just going to shoot your own lung because it doesn't realize what's going on. The alveoli will completely collapse. When they collapse, it traps air inside of them, yes? So can you get your oxygen in very well? No. Can you get your CO2 out? No. And they're going to be breathing in so hard that their chest is actually going to hyperexpand and remodel, causing barrel chest. And when your lungs go really big and they hyperinflate, they squish down your diaphragm, and then that makes it even harder to breathe because what's your diaphragm? The muscle of breathing, right? So the diaphragm becomes flattened, not widened, just flattened. It's not Play-Doh, okay? You with me? All right. We will end up getting what's called a ventilation perfusion mismatch. What does that mean?
When you're breathing and you're not perfusing, or when you're perfusing, you're not breathing.
Yes, so you're either pulling in air, but you can't perfuse, or you're perfusing and you can't bring in air. Now, if they divide out emphysema and chronic bronchitis, it usually starts out as emphysema and then you get episodes of chronic bronchitis. But emphysema, they can pull in, they're having a hard time pulling in air, but they're perfusing enough. That's why we call emphysema a pink puffer, because they're still pink. Yeah. They're perfusing enough. But have you ever seen somebody with emphysema breathing? And it's every breath. They said they feel like they're under like 2 inches of water. Like if I'm looking up right here from a swimming pool and the water's like right there, you can You feel like you could get up, but you can't get up. So you're just like constantly like right underneath. They get very anxious, so much so that we give them benzos to calm them down because they're so air hungry. Okay. All right. What's the number one cause of COPD? Smoking. Number 2 is occupational chemicals. Okay. There is also a genetic form of COPD where you could have never smoked a day in your life. It's called an alpha-1 antitrypsin deficiency. Okay. So these are non-smokers. All right. But they have a issue with their genetics. And so it causes COPD, causes their lungs to get attacked. All right. Biggest risk factors for COPD. These all make sense, like dust, air pollution, the older that you are. Now, it happens more to white females, okay? If you have recurrent lung infections where there was already scarring there, or if you're in a household with somebody who smokes. My grandma was in a house with my papa. He smoked a pipe for 50 years back when it was like really popular. Everybody did that, right? And they lived in this teeny tiny house. And so she breathed that in for 50 years and now she has COPD. She's never smoked a day in her life, okay? If you had TB, which can cause lung scarring, asthma, which can cause lung scarring, now, these two are not causal, but they can contribute too. If you have poor nutrition or low socioeconomic status, you are more likely to develop COPD, okay? It may be that population does have a higher smoking rate. It could also be that you don't have the nutrients that you need in order to maintain healthy lung tissue, okay? So there could be a lot of things that go along with that.
So TB and asthma not causal, but
no, those two can contribute. Risk factors are things that can contribute. Okay. All right. So signs and symptoms, they usually don't develop until after age 50. You would have to smoke like 20 or 30 years to get COPD. Okay. So it takes a minimum of 20 years of cigarette smoking to develop. Now, what I did here was I put the most common signs and symptoms, then what happens when it progresses, and then what happens at end stage, the complications. Does that make sense? Yes. All right. So the first set of signs and symptoms is you have dyspnea. Obviously, we talked about the flattened diaphragm. We talked about barrel chest. Coughing, wheezing, lots of sputum. They always have crackles. So are we ever going to report that? No, because they live that way. It's constant. They may have decreased breath sounds because at the bottom, they're going to have atelectasis. They have an increased AP diameter. What does that mean? So because you should be wider this way than you are this way. They become equal like a square. That's what the barrel chest is. So these are equal, okay? They will have retractions. They come in tripod and they do pursed-lipped breathing. What is pursed-lipped breathing? CO2. All right, so it's the body's natural way to blow out the CO2. So they'll breathe in and then, and they're trying to correct respiratory acidosis. Yeah, it looks like they're whistling. Okay, so on top of those symptoms, they also have weight loss. Why would they have weight loss? They can't eat because they can't breathe. You have to choose between eating and breathing. You're going to choose, well, most of the time. All right, anorexia. They don't feel like eating because they're in such distress, right? They're tired and they can't tolerate any activities. Why would they get frequent infections? Mucus just sitting there. Anytime mucus sits there, it's going to get infected. They feel severe anxiety, right? Because they are air hungry. They're trying to pull in and work really hard for every breath. Here's our big red flag. Report. Pink, frothy sputum. What does that tell me? Pulmonary edema from the pulmonary hypertension, right? The pulmonary hypertension changes pressure, right? And it leaks into the third space, which causes pink, frothy sputum in the alveoli, which is the third space of the lungs. Yes? All right. If we do not fix this, it will lead to hypoxia. Okay. So hypoxemia, you'll know they have that because their SpO2 is less than 90. Hypoxemia is oxygen in the blood. So that would be a PaO2 of less than 80. Y'all remember the difference between the pulse ox and the PaO2, yes? Okay. Hypercapnia, which would be a PaCO2 of greater than 50. And how do we draw CO2? ABGs. They will end up in a respiratory acidosis. We already talked about that. Pulmonary hypertension, pulmonary edema. What's number one sign and symptom of pulmonary edema? Pink, frothy sputum. Okay. They can end up with cor pulmonale. What is that? Yes. Tell me more. It's a what? No, you're thinking chronic bronchitis. Uh-huh. What's cor pulmonale? Yes.
Oh.
So what happens, let me just show you really quick. In congestive heart failure, what fails?
In congestive heart failure.
Right, the heart fails, right?
Yeah.
And then fluid goes back to the lungs and
Yeah.
fills the lungs with fluid, yes?
Yeah.
Okay. So that's congestive heart failure, right? The heart is a crappy pump and it leads to all the fluid goes into the lungs and causes lung problems.
Mm-hmm.
Cor pulmonale is the opposite. The lungs are already filled with fluid, so that backs up through the pulmonary artery into the right side of the heart. So it's where your lungs are jacked, and that causes right-sided heart failure. So do you understand the difference?
Yeah.
CHF is where your heart fails and causes lung problems. Cor pulmonale is where your lungs are failing and causes right-sided heart failure. Does that make sense?
Yeah.
Okay. So that's a complication we do have to watch for. You with?
So core pulmonary is where the lungs are messed up and it backs up and messes up the heart. So right side heart failure.
All right. What's polycythemia?
Excess red blood cells.
Why do they have so many red blood cells?
They're dying. No, the red blood cells are dying, so their body.
The red blood cells are not dying.
Polycythemia.
Why do they have it?
Low oxygen in the blood and
Yes.
the bone marrow is produced. No.
Go.
You're going.
The body senses low red blood cells and producing more.
Yeah.
How? How does it do that? What tells the bone marrow to make more red blood cells? That's a hormone. And y'all know it, 100%. Yes. So these patients are hypoxic. When you go hypoxic, that gives a signal to your kidneys to produce erythropoietin. Erythropoietin is a hormone that tells your bone marrow to make more red blood cells. And then that's supposed to cut off the hypoxia. But in this case, it doesn't because they have chronic hypoxia. So they're constantly getting the signal, erythropoietin, make more. What two things does polycythemia put you at risk for? What does it do to your blood?
Hypertension.
Hypertension, what'd you say? That's right. The second one is clots. Okay, hypertension and clots. They are also going to be cyanotic. And polycythemia, what color do they turn? Red. And cyanosis, what color are they? Blue. So if they're blue and red together, they turn purple. Okay. They are at risk for clots. We understand that. Clubbing. What is clubbing?
That's when they have long-term respiratory.
So the nails
Goes up greater than
curve.
180.
Yes, they curve down. Yes. And that tells me that they have chronic hypoxia. Okay. Why would they get peptic ulcer disease?
Because of the fluid
Inflammation
Oh, where's peptic ulcer disease?
and the gastric.
In the stomach. Okay. What causes peptic ulcer disease?
Stress.
Oh, so what hormone are they producing since they're so stressed? Cortisol. What's function number 11 of cortisol? Acid secretion. It increases stomach acid. So that's going to cause peptic ulcer disease. And then they get very depressed and very anxious because they constantly cannot breathe. And that is terrifying. And it's very hard. They can't eat like normally. And that makes us happy. And it's hard to go and do activities with your families and things because you can't breathe. So that can cause depression and anxiety. Do we understand so far? Moving on. We diagnose COPD the same way we diagnosed asthma, which was how? Pulmonary function test. We'll do the same thing we did before, like a history, physical. We do need to draw alpha-1 antitrypsin levels, because what is that?
Genetic.
That's the genetic form of COPD. Okay? Why would I do an EKG?
To look at their heart, because right side heart.
So I want to make sure they're not starting to get cor pulmonale. Very good, very good. And I'm also going to do an echo just to make sure. Okay? I will do something called a Bode index. Did y'all talk about this?
Mm-hmm.
It's like they take the patient's BMI, which should be less than 25, and their dyspnea level. So we're like, hey, go take a walk and let's see how short of breath you are. And then they use that to diagnose. Obviously, if you're a little more heavy, it's going to make you a little more short of breath. So that's what they're kind of comparing. They want to see like what you actually, what you're doing. Yeah, here. And then in the PFTs, the pulmonary function test, if your FEV is less than 70%, that is diagnostic for COPD. What is an FEV? I'm sorry. FEV. I know, it's a day. Y'all want to go home. And I get that. I get it. I'm proud of y'all for coming in on a holiday.
FEV.
I don't know.
Function.
Remember, what did we say PFTs were? But what are they? How do you perform them? But you put them in the, and then there's a pipe that comes out of the ground. So I want them to force their air in. Forced expiratory volume. Yeah. If it's less than 70% of what it should be, because this is an obstructive disorder, right? They have a hard time getting air out. Then that would make sense, would it not? And then we do a 6-minute walk test. Remember I said like, hey, go take a walk. Let me compare your BMI just to make sure. And then let's see how far you can walk without being like, and that's how they diagnose. Ain't that something? All right then. All right. Sorry, don't hate me, but we also have stepwise therapy, okay? Stepwise therapy for COPD. Oh no. I hate it. Okay. And it doesn't follow the same as asthma, of course. So stage 0. I hate that. This is so dumb. You don't even have it. You're just at risk. So if that's the case, we're like, here's your therapy. Avoid your risk factors. Yeah. All right. Stage number 1 is considered mild. Now this does follow the same. Mild, we do, what's first line treatment? SABA PRN. And that is a rescue or maintenance? Rescue. All right. Step number 2 is considered moderate COPD. At that time, we're going to add a LABA. What's a LABA? Not low. Long-acting beta agonist. I can give y'all some examples because I don't think I did that last time. An example of a LABA would be salmeterol. Sounds a lot like albuterol, right? Because it's albuterol is a SABA, and salmeterol or formoterol is a LABA. Okay. Now, LABAs, are they rescue or maintenance? Rescue. No, they can't be rescue because they're long-acting. LABAs would be maintenance. SABA would be rescue. Good. All right. So in stage 2 moderate, we're going to do a LABA. And then y'all know in nursing school, and this is for you too, Penny, every time they say send the patient to rehab, yes. The patient has a heart problem, send him to cardiac rehab. Yes. The patient has a lung problem, send him to pulmonary rehab. Yes. The patient has an alcohol problem, send him to alcohol rehab. Yes. They love rehab. Always pick it. Okay? There's never a time in a select apply you would not pick rehab. It's like the good hand washing. Okay? All right. Stage number 3 is severe. We're going to add an ICS with it. What's an ICS? Inhaled corticosteroid. Which drug is that? Fluticasone. Stage 4, very severe. We're going to put them on long-term O2. So they're going to have a little canister that they drag around behind them. Y'all have seen little people like this, right? Yeah. And then they may or may not need surgery to cut out the parts that are become completely fibrotic. But honestly, by that point, most of it's fibrotic. So you can't just like, I mean, you could, I guess, but it would be like maybe more trouble than would help them, right? Yes. She said, oh, that doesn't seem like it would help. I mean, you can do like a lobectomy or something, right? But I don't know. All right. So different bronchodilators we're going to use because COPD, look at me. COPD has the same 3 pathological processes as asthma. Number 1,
Bronchoconstriction.
Number 2,
Vasodilation. No.
Airway.
Inflammation.
Number 3,
Mucus production.
So how do we fix the bronchoconstriction?
Bronchodilator.
How do we fix the airway inflammation? Inhale corticosteroid. How do we fix the mucus production?
No.
In this case, you're going to do, how do we dry it? What's your dry?
Anticholinergic. What is your anticholinergic drug? Yes.
Hypertrophium.
Hypertrophium. I think we got it. Oh my God, y'all. This is a lot and this is hard. It's not easy. All right. So bronchodilators we would use for our COPD patients. We're going to start with the SABA. What does the SABA stand for?
Beta agonist.
Give me an example of that drug. Albuterol. That one's the long acting. Those are the long acting. Okay. What is a LABA? Long acting beta agonist. 2 examples. Salmeterol, formoterol. We could give ipratropium. What's your keyword for ipratropium?
No, that's gonna anticholinergic. No.
Yeah, it's an anticholinergic and a bronchodilator together in one. Okay.
Okay, let me write this down.
We could give theophylline. What's your keyword for theophylline? Crack for the lungs could give you a massive fight or flight. What can you not do if you're on theophylline? Smoke, drink caffeine, right? Do anything that would cause you to be any more up than you already are. Okay. The surgery they may perform is called a lung volume reduction surgery. That's LVRS. So they're like, let me just cut out this part, okay? It's fine. Burp. All right.
Does it go back?
Your lungs, sometimes they can.
Oh.
They can't completely regenerate like the liver can, but some of the tissue can come back, but you're never going to get a full lung again. Okay. Now the liver can totally regenerate itself. All right. Anticholinergics. This would either be ipratropium or tiotropium. Okay. Now these come in like they're a DPI. What's a DPI? Dry powder inhaler. Remember, those come in a pack that looks like birth control. You pop out the pill, you put it in the inhaler, you slide the door, and it crushes the pill. COPD patients are notorious for not knowing how to take this medication because it was not taught to them. So if a COPD patient comes in, they're like, man, I'm taking my medicine every day and it's not working. What would you say? Show me how you take it. And what they will do is they'll pop the pill out of the birth control thing and they'll take it with a glass of water. And you're like, oh no, we just need to re-educate at that time. Yes?
Yeah.
Okay. And then corticosteroids, which end in Sone or Salone. Sounds like Sylvester Stallone every time I hear it. Salone. Yeah, you're going to come in 10 years and be like, hey, this is my son. His name is Stallone. All right. Number one thing you teach your COPD patient. Do not smoke. Okay. The patient is getting wheeled back to get both of their lungs removed. What would you whisper into their ear as they're going into surgery? Stop smoking. I don't know why. They will always say the most ridiculous time to say it. And they're like, what's your priority? And it's like, teach the patient to stop smoking. Bro's like crying over his lungs that are about to be gone. You can't take out both lungs. Y'all know that, right? It was just a joke. Okay. So for oxygen administration at home, I just wanted to remind you guys of a couple things. Okay. They go on nasal cannula for maintenance, right? Now, if they're in the hospital and they're in exacerbation, usually you're going to pick a Venturi mask. What is a Venturi mask? It's not a non-rebreather.
No, it has different settings, right?
It has different valves that you put on to give a specific amount of oxygen. So this is very important. Everybody look. If they ask you and say you get an order for 70% O2, which mask will you choose? It is, because it's going to give you a specific amount. If they say, I want this amount. Because if they say, hey, I want 90% oxygen, how y'all going to give that? How would you know it's 90%? You see what I mean?
Yes.
If the patient just is in COPD and they're in acute exacerbation, they get wheeled right into you to the ER and then what am I going to use? Non-rebreather.
Okay.
Because you can give up to 100% non-rebreather. Okay? So acute exacerbation or acute shortness of breath, you use, y'all, non-rebreather. If they ask for a specific amount of oxygen, then you're going to choose a Venturi. Do we understand? Do y'all know what a non-rebreather is? It's the one that has the bag on the bottom. It has to be at least halfway full or they ain't getting nothing. Okay? All right.
So we use non-rebreather.
Correct. Yes. Yes. Unless they say, hey, I want this percentage, and then you would use a... Okay, I think we got it. All right. Now, they used to have this rule, and it should still be in effect, to not use more than 2 liters of oxygen. Why don't we use more than 2 liters of oxygen for COPD? Well, they do, but...
Oh, ventilatory drive.
Okay, so our drive to breathe is... What's our drive to breathe? What makes you breathe?
The pressure.
What tells you... Have you been... This whole time we've been here, have you had to tell your body to breathe one time?
No.
What makes it breathe? What tells you... What? She said, I don't know. I'd like to know because it's been doing a very good job for a very long time. What is our drive to breathe? Interesting. It's always the simple questions, you know? But nobody ever teaches you the simple stuff. Huh? Oh.
You have lungs.
Well, you do, but there has to be something that tells your body, like, now's the time you need to take a breath.
Your heart?
What?
I don't know.
Okay.
I don't know.
It's not a body part.
Oh.
There has to be something that signals to your body, like, it's time to take a breath. What's happening in your alveoli?
Yes, it's changed.
Right. What did we call it?
The wheel.
The water wheel. So something has to tell your body you need
The
to.
CO2 going up.
Yes. High CO2 is what signals us to breathe. Because as your CO2 starts to rise, it says, oh, we need to turn the water wheel. So you let it, okay? But in patients with COPD, what's their CO2 level like? It's high all the time. So their switches from high CO2 to low O2. That becomes their drive to breathe. So what happens if you give them 15 liters of oxygen at 100%? They won't breathe at all because their drive for breathing will be no more because you fixed their hypoxia problem.
Oh my God.
Okay? But I will tell you all this. In the past year, ATI has changed this, and they said give them whatever oxygen they want.
Why?
I do not know, but I'm letting you know because I made a really big deal about this because this is always on NCLEX, a really big deal. Like, you can't just go and give them as much oxygen as you want if they have COPD. And then somebody screenshotted me. Well, I shouldn't have said that.
That's okay.
Somebody screenshotted a picture of the book that they read that had test questions in it. And it was like, hey, what do you do for a COPD patient? And their SpO2 is 88% and they're on 2 liters. And it was like, move them up to 5 or 6. So there is a change now. I do want to let y'all know that. So do with that what you will. Huh?
I saw that in the hospital at TDCJ.
Oh, well, TDCJ will do pretty much.
Yeah, she
Yeah.
moved it up to like 5. The resident told her to. She moved it up to 5 liters.
Interesting.
And his CO2
You just
was at,
really
like,
got to watch
82.
the respiratory rate.
Yeah, he was at like 82. And I was like,
Hmm?
oh, yeah.
All right. So make sure that when you're using oxygen that it has to be humidified. Otherwise, you're going to dry out their mucous membranes. They're going to start bleeding. All right. We don't want that. Airway maintenance. You're going to teach them pursed lipped breathing at 2 to 4. What does that mean?
Yeah.
Breathe in for 2 seconds and out for 4 seconds. You want your expiration to be twice as long as your inspiration because you're trying to blow out your CO2. Very good. Tripod, or they also call it the orthopneic position. Do you report that? No, because they are having trouble breathing. We just let them do that. And y'all got to think, anytime they say, what would you call the physician for? What do you want them to do when they get there? Like if I called the doctor, was like, doctor, come quickly, the patient's in tripod. What do you want me to do? Force them to sit up? You know, like, what do you want? You see what I'm saying? Yeah. So it have to be something you call the physician for where you actually need them to do something that they can fix. Teach them abdominal or diaphragmatic breathing. This is actually very good breathing for everyone. We're not supposed to breathe with our chest. We're supposed to breathe with our diaphragm. This is how they teach you to breathe in choir or if you're in band or anything that requires any type of large lung capacity. So you have them put their hand right here on their belly and you want them to like push out their stomach. Yeah. Yeah. Their diaphragm is a little flattened, so it's something you have to practice for a long period of time. Huh? Yes. Actually, this is how they teach you to breathe in meditation. This is how they teach you to breathe in yoga. It's much better to belly breathe than it is to chest breathe. Huh? Okay, then you need to work on it a little more, sister girl. All right. Let's see. What else you need to know? Oh, okay. We're going to perform CPT. What is CPT?
No.
Chest.
Pulmonary.
Physiotherapy.
Oh my God.
That's where they put the vest on and they shake them. Yeah. Okay. And then they will also do pulmonary toilet. What's pulmonary toilet?
Is that the one where they're like...
That's part of it. So pulmonary toilet is an umbrella term for all the things that RT does to break up the mucus. Underneath pulmonary toilet, you would see percussion. That's what you were describing, where you hit on their back with different like items to kind of break it up. Do you remember postural drainage from first semester, where they put the patient in different positions to drain out the mucus? Yeah. Okay. So when you see the words pulmonary toilet, that just basically means what are the different ways that RT will help them to expel mucus? Okay. The huff cough technique, what is that?
Cough, like bring it up like that.
You know how like when you're sick and when you take a deep breath, it makes you cough? But they want them to do that because they want them to cough up the mucus. So they'll tell them to like sit on the side of the bed, take a big deep, and as soon as they go, it's going to make them cough because it's going to initiate that reflex, okay? And so it will help them to cough. And you want them to force the coughing out because you want the mucus to come up. You with? TCDB Q2. What's that? Turn, cough, deep breathe, Q2. Keep things moving.
Every 2 hours.
Yes. Nutrition support, small frequent meals. Remember, you will always pick that in nursing school. There's never a time you will not pick that. Okay. SABA before meals. Why would I have them do a SABA before meals? So they can breathe to eat. What is your SABA? Albuterol. And they're going to do oral care before meals. That's a nursing school thing. You will always pick that for every patient, even though it's totally gross and nobody ever brushes their teeth right before meals. That's what we going to do. Oh my God. That is so crazy. All right. Goal BMI is 21 to 25 because remember, they're super skinny. So our goal is going to be a little bit lower than normal. Okay. We want them to rest for 30 minutes before they eat. So basically, here's their eating routine, right? They're going to take a little nap, 30 minutes. Wake up. Swish it, right? You got to rinse afterward. And then they eat. It's a lot of work just to eat. Yeah. All right. When they are eating, you want to recommend cold or cool, easy to chew foods. Nothing very hot because you don't know how you act when it's hot. Because you got to do that, right? So it's going to be something that's really easy to chew that's high calorie too. So usually what they put on exams is pancakes and syrup for COPD. It's easy to chew. They always put that on tests. It's easy to chew. You can add like butter or syrup or whatever to increase the calories, fairly easy to make. So you want high calorie, high carb because carbs are easy to digest and easy to chew. Moderate protein, okay? Remember, anytime somebody's having trouble breathing or they're having we can't digest very well, you're never going to pick high fat, right? All right. IV fluids, if they're in exacerbation, 3,000 liters a day is minimum. If they're at home chilling, 3,000 liters a day is minimum. 3 to 4 is where you want them to be. All right, goals for this patient would be a BMI of 21 to 25, SpO2 of greater than 90. We're changing our protocol. Usually everybody else it's 95, right? But for this patient, they run low all the time. Are you going to call the doctor for an SpO2 of 92% on a COPD patient? No. Would you call for an 85%? Probably, yeah. PaO2 of greater than 60 because what's the actual normal number of PaO2? 80. So we want them to be at least at 60. Okay. O2 home teaching. I added this because a lot of y'all haven't had this since first semester and that's been a minute. If they even ever taught it to you, I don't know. You need to pad the pressure points, which would be around their ears where the nasal cannula, the tube goes. Otherwise they're going to have breakdown around their ears. Use water-based gel on lips. You cannot use petroleum jelly or their lips will spontaneously combust because it's flammable. Wouldn't that be a way to go? Frequent oral hygiene because it does dry them out, right? They can only wear cotton clothing. Everything else is flammable. Okay. Do not cook and do not smoke when you on your oxygen. Okay. Notify the electric company. Why do we do that?
Because they need to get the shutdown.
They'll need to be the first people to get their power back. So if they know that they're a requirement, they're on an oxygen requirement, they'll give it back. Keep O2 less than 2 liters O2 unless you're taking the ATI and humidify the oxygen. Okay. Here's our friend, pulmonary rehab. Yes. All right. Home teaching. We do want to refer to occupational therapy. What do? They help them perform their ADLs given their limitations. So for them, it's going to be self-care, like how are you going to shampoo and get in the shower and do all that when you can't breathe? How are you going to cook some basic meals when you can't breathe? Okay. Walking as exercise. We do want them to walk and to move around. So they will use their SABA 10 minutes before they go to exercise. And then they need to exercise 15 to 20 minutes a day, 3 times a week. This is the only time in nursing school. It's not 30 minutes a day, 5 times a week. Okay. Bronchodilator before sexual activity, because you do need to talk to grandma and grandpa. They are very sexually active still, and you need to make sure that they can do so in a healthy way. That is not the way to go. 3,000 liters of fluid minimum per day. Yearly fluid pneumo, just like you got for asthma. Thank you. Good. Hand washing will 100% be the right answer always. Yes? Refer to a support group because it is tough, right? And report any signs of infection. Very briefly, I gave you a little crash course on what to do if they're in exacerbation right here in this pink. Okay. So they come in for asthma exacerbation, for COPD exacerbation. What's the first thing you're going to do? Sit them upright. And then auscultate, put them on a pulse ox. Give them a plus albuterol plus hypertropium. Oh, look, it's the same as the asthma. That's so wild. And then we're going to put them on IV IV fluids, corticosteroids. Are they okay to try pod? Yes. And then we probably will give antibiotics only because most COPD exacerbations happen because of an infection. Look how easy that was.